A very good morning to one and all. So I'll be presenting the topic on effectiveness and future implications of COVID-related risk stratification in managing retinopathy of prematurity, the Indian Twin City report number 10. So these are my affiliations. I have no financial interest. So as we know, the COVID wave hit us like a tsunami wave in 2020, with most of the essential services were closed. But ROP was a very important essential service that needed utmost importance, and it is a time-bound disease. So we could not halt this, and it has to be in progress. So the Indian ROP Society came with a set of guidelines. It included both the safety guidelines as well as the risk stratification guidelines. So we kind of validated these Indian ROP Society guidelines to see how effective this is. So the safety guidelines, as we know, here is the proper hand hygiene or sanitization, or see the quarantine stamp of the parents, and also the face masks and other proper COVID gear. And the risk stratification guidelines, where the Indian ROP Society divided the babies into high risk and low risk. Low risk are the babies which are systemically stable, which have good weight gain, and who are above 34 weeks of postmenstrual age, and who are more than 1,000 grams of birth weight. So in low risk babies, we kind of try to reduce the frequency of follow-up, because we have limited resource during COVID, and give the maximum outcome and make sure none of the babies went into retinal detachment. Whereas the high risk babies, the very low birth weight and other babies, we followed the old guidelines itself. So we strengthened our outreach services. So we can see, out of the 200 babies screened during the first wave of COVID, the majority of 143 babies were from the outreach hospitals in and around Hyderabad, whereas 57 were from the Apex Center. So let us see some of the safety guidelines that we followed. So here we can see the mother will place the baby in the cradle, and we do not want any of the sisters or mothers to overcrowd there. We ask the mother to step behind, and only the doctor screens. The doctor screens the baby under the radiant warmer, connecting all the monitors. And with this, we can reduce the transmission of COVID to mother or the sisters or the doctor, or the transmission to the baby itself. So we do not want too much of crowding to happen. This is in a very stable babies that come to our OPD. So if the babies were much more sick babies, or which babies in NICU, we use these acrylic boxes to screen the babies. So we can see these are acrylic boxes which have hands, these kind of protect the babies from this COVID transmission from the doctor or any other attendant who are nearby. And it has a nice hand holes to where we can easily screen these babies. So by this we can reduce the COVID transmission to the babies, as well as the parents or the sisters, and also the doctors. So these were the safety guidelines that we took into account. So what are the stratification guidelines? So I said these stratification guidelines were followed only low risk babies. So low risk babies with very mild ROP, we kind of reduce the follow-up, or we extended the follow-up by 1 week. That is, if it is zone 2 anterior or zone 3, we kind of reduce the follow-up by 1 week. That is, we postponed the follow-up by 1 week. Whereas if the baby was pre-plus, and if pre-plus babies we treated early, because pre-plus babies, there are high chance of them losing to follow-up if you call them in the next week. So we treated the pre-plus early, because the apprehension of the parents to reach the hospital, or if they miss the follow-up. So anticipating this, we treated the pre-plus early, whereas very mild ROP we reduced by 1 week. And if the babies had AP ROP, which needed immediate anti-VEGF injection, then we gave the anti-VEGF injection on the same day, and we followed this baby by teleconsult. So we did not want to call the baby after 1 day to check whether the baby has endophthalmitis or not. This follow-up can be reduced by doing teleconsult, where the parents will, or the NICU neonatologist will send the WhatsApp image or the email with these baby photos. So if at all baby has lid edema or congestion, that will alarm the treating doctor that the baby has endophthalmitis. Then only we call them to the clinic. Same for even the surgically treated stage 4A or stage 4B ROP also, we kind of reduce the follow-up by teleconsult. So we found out that in our study, that with this new validation of the IROP Society risk stratification, that none of the babies with no detachment went for detachment. So this is no way a suboptimal. This is a calculated risk that was taken in low risk babies to reduce the number of frequency and the transmission of COVID. So we found out that none of the babies went for detachment. So the new risk stratification is no way suboptimal. It can be easily, it's a calculated risk that is taken in low risk. And of course, the risk stratification and the COVID safety guidelines, both in terms of increasing the, reducing the frequency of follow-up is important. So we found out all these, not just the doctors, even the neonatologists, nurses, technicians, drivers, housekeeping and security staff all played a hand in role. We might have forgotten this now, but during the pandemic, it was very important that teamwork and coordination did the work for us. Thank you.